Okay, good evening, everyone.
Good evening.
Yeah, I think we've waited for about 8 minutes. It's some good time, so maybe we can start. Um, well, today we're going to be doing essentially the anatomy of let's summarize anatomy of the brain. Um, Start with the lateral cortical surface, talking about things like the Brodmann's area and some other important structures. We talk about the other anatomical locations, including the central sulcus, somatotopic arrangement, the hand knob or the omega sign, craniometry, surface craniometry, um, and then yeah, majorly craniometry, and then the foramina, the important foramina, and yeah, the internal acoustic axis, and essentially that's where we're going to stop. Um, sorry, internal capsule anatomy, architectural anatomy of the internal capsule. That's what we're going to start, essentially. So Monday before we can continue with Greenberg. So essentially, that's it for now. So we're going to start. So um, the according to Greenberg, this is there are abbreviations on table on this other side of the screen. I don't know if you can see my screen, just to share both pages to make it very easy. For the Brodmann's area, sorry, the middle frontal gyrus is more usually sinus than the inferior. So anyway, on the lateral surface of the cortex, you have the frontal lobe, the frontal cortex, which is limited by the central sulcus. Posterior to it, you have the parietal lobe, which extends as far as the posterior to the upper limb of the sylvian fissure, limited posteriorly by the angular gyrus. And then you have inferior to the parietal lobe, we have the temporal lobe here. And then posterior to both the parietal and, sorry, both posterior to both the parietal and temporal lobe, we have the occipital lobe. Now, the frontal lobe has the superior frontal gyrus, middle frontal gyrus, and the inferior frontal gyrus. The inferior frontal gyrus is particularly important because it's divided into the pars orbitalis, uh, pars, um, pars triangularis, and pars opercularis. And the important thing here, located here, is the fact that the pars or the par ranging in between the par triangularis and par opercularis is the Brodmann's area 44, which is referred to as the Broca's area, which is the frontal speech or motor speech area. Of course, the frontal lobe has various functions, as we all know. Speech function, the speech function, it has motor function, and it has executive function, and also important in memory. Majority of the more proximal parts, as the more proximal parts of the frontal lobe have relationship with executive functions, behavior, and memory, while the more parts closer to the central sulcus are more important in motor function. and subsequently other information that will be discussed on the book. So here they mentioned that the middle frontal gyrus is usually more sinus than the inferior frontal gyrus or superior frontal gyrus. Often connects the placental gyrus via a thin isthmus. So placentral gyrus, middle frontal gyrus. This location here where my cursor is the isthmus. I don't know if you can, anyone, if my cursor is visible. Hello? Am I audible?
Yes, yes, you are audible, and we can see your cursor also. We can
Okay.
see.
Okay, great. All right. So, so this is the isthmus that connects the middle frontal gyrus to the central gyrus. Now, it's also said here that the central sulcus joins the sylvian fissure only in 2% of cases. That is, 98% of cases there's a subcentral gyrus. The intraparietal sulcus, so this happening at this sylvian fissure does not connect to this, that's the central sulcus, in more than 98% of cases. It's only in 2% of cases that you see this connecting to this. So this here is called the subcentral gyrus. This area here is called the subcentral gyrus. Okay. Also, it's mentioned that the inferior parietal lobule, sorry, the intraparietal sulcus separates the superior and inferior parietal lobules, and the inferior parietal lobule is primarily composed of the angular gyrus and the supramarginal gyrus. The sylvian fissure terminates in the supramarginal gyrus, followed area 40, and the superior temporal sulcus terminates in the angular gyrus. So here, this is what they are talking about. You have, of course, we all know this is the lateral sulcus or the sylvian sulcus or sylvian fissure, which separates the frontal, parietal, and the temporal lobe. And then going through here, have going upwards, the smooth curve upwards towards the parietal lobe. You have the in the inferior parietal lobe, you have the supramarginal gyrus here, which is the SMG, and that's it. That's where it terminates the sylvian fissure. And then on the other side, you have the superior temporal sulcus terminating in the angular gyrus. And both of them together form Brodmann's area 40, which is for SMG, and Brodmann's area 39, which is where the angular gyrus is located, and both of them form the Wernicke's area, which is sensory speech area. Okay, so proceed. Proceed to the rest of the information here. Sylvian fissure terminated on this. Okay. So the next is the Brodmann's areas. We've already started talking about some of them, but we'll start. So Brodmann's area 312. That's here. So 312, as it is arranged, forms the central gyrus. Because I don't know why this Brodmann's person decided to be very non-methodical about the way his gyruses are arranged and why even numbers were given to motor while odd numbers were given to sensory part and this thing. I don't know why he did all that. So decided to become the problem for all of us. But anyway, this is this arrangement. So, post central gyrus is made up of Brodmann's area 312. And the precentral gyrus is made up of essentially Brodmann's area 4. The premotor cortex, and the precentral gyrus is made up of the motor strip, which is Brodmann's area 4, and then the Brodmann's area 6, which is the premotor area. And then you have I think, motor association area, which is frontal eye field area, which is Brodmann's area 8, is anterior to the premotor cortex. So all of them are actually motor. So motor eye field area, Brodmann's area 8, more proximal, followed by the premotor cortex, Brodmann's area 6. It's also called the supplementary motor area. And then the motor strip is Brodmann's area 4. Then continuing, we have in the superior temporal gyrus, we have Brodmann's area 42 and 41, which is responsible for auditory impulses. So the primary auditory area. And it is called the transverse, it is located in the transverse gyri of Heschel, Heschl, Heschel. And then, of course, we've already talked about the motor strip area. And Brodmann area 17, which is calcarine, we've aligned the calcarine sulcus, which is the primary visual cortex. These are the most important Brodmann's area for the basic neurosurgical residents. So we move to medial surface of the brain. So the cingulate sulcus terminates posteriorly in the pars marginalis, and an axial image in the pars marginalis is visible in 95% of CTs and 91% of MRI. Usually, the most prominent of the PET groups straddling the midline, and they extend a greater distance into the hemisphere. On axial CT, MRI pars marginalis is posterior to the widest biparietal diameter. Posterior to the widest biparietal diameter, and the pars marginalis curves posteriorly in lower slices and anteriorly in higher slices. Hence, the paired pars marginalis forms a pars bracket called the handlebar configuration, straddling the midline. Okay. When we assess both images. And there's also the anterior commissural posterior commissural line, usually referred to as the ACPC line. What I just described earlier is the cingulate sulcus continues posteriorly as this pars marginalis. In lower slices, it appears to be straight. Then, sorry, here, if you're up, it appears straight, and down, it appears a bit more curved posteriorly. So that's what we've been talking about. So, and then when you merge both together, you have it here. On this MRI image here, you can see the pars marginalis appearing like a bucket handle, a bracket handle here, like a T. If you look at it, it's like a T shape, so that's the pars marginalis merging on across the midline. All right, so you have the ACPC line connects the anterior commissural and the posterior commissural on the midline sagittal image. And it's supposed to be like an orientating line for MRI imaging or CT scan to be used as functional neurosurgery, and it's used as a baseline for axial MRI scans and recently CT scanners. Before, it used to be the Taylor-Huntington's line, I think, that used to be used, or something like that. The Frankfurt plane used to be used. So I think they are moving now towards the ACPC line. The anterior curvature is horizontally oriented white matter tract connecting the left and right cerebral hemispheres that cross in front of the fornix. The PC is a white matter band at the level of the pineal. Anterior is actually anterior to the pineal gland. Crosses at the posterior third ventricle. Anterior inferiorly and anteriorly to it, to the pineal gland. And it's posterior to third ventricle. Yeah. The ACPC line is used in functional neurosurgery and is used as baseline for axial MRI scan. Yes, more entrenched, the Tyler Arch definition passes through the superior edge of the AC and inferior edge of the PC, as seen here. Superior edge and inferior edge. Posterior commissure. This is the posterior commissure here. You see the small band here, that's the posterior commissure. And then, of course, the anterior commissural fibers here. So this is AC, this is PC. Above the AC and below the PC, that's what they mean. So it crosses like that. And yeah, alternative, there's a Schlattenbrand definition of the ACPC line that says it passes through the midpoints of both the AC and PC, allowing both the AC and PC to be imaged on a single line passing through the image on a thin MRI slide. This definition is divided by 5.81 plus or minus 1.07. And there's also the orbitomeatal line, which has been used in older CT scans. And it's approximately 9 degrees steeper than the Tyler arch ACPC line. Okay. All right, so essentially, then we'll move to the commonly described homunculus, which is the somatotopic organization of the primary sensory and motor cortex. The primary motor cortex, as motor strip, and primary somatosensory cortex are organized somatotopically so that specific regions of the brain map correspond to specific areas of the body as shown in figure 1.3. This is figure 1.3 here. You can see that, of course, unlike, so everything is like upside down. The genitals usually last in the sensory, the toes are lasting. And so essentially that's how it is. The human is inverted. The most lower point here is intra-abdominal. Here is swallowing essentially. So I can just have a look at that in the book. It's not so very, very necessary. The regions are often drawn in a caricature of human along the labels shown there. Some key points to the representation of the arm and face are draped over the convexity of the brain, while the foot and leg are located along the upper aspect of the medial surface. Areas with fine motor or sensory function like finger, tongue have a larger area of representation. Yeah, so the more the function, the wider the area of representation. Okay. For the central sulcus on axial imaging seen. So an important imaging finding here is the central sulcus, which is usually referred to as the omega sign or the hand knob. It's usually identified, seen in 93% of CTs, and almost all MRIs can show the central sulcus. And it curves posteriorly as it approaches the interhemispheric fissure, and then terminates in the paracentral lobule, just anterior to the pars marginalis within the pars bracket. The central sulcus often does not reach the midline. Yeah. So this is what you usually have here. It goes like this. So you can see on this side, you can see it here. This is pars marginalis. So if you're looking for it, first go find the pars marginalis, which is the only line that crosses the midline bilaterally on MRI. And then you now go anterior to it, you find the anterior limb of it, then you now trace it. And you see that classical omega sign, and that gives you the central sulcus. And central sulcus, and then anterior to the central sulcus crosses the motor strip. So it helps you plan surgery, delineate a lot of things while you're patient. Yeah. So essentially that's it. And if all right, so the next is okay, so they talked about the perioccipital sulcus of fusion, which is more prominent over the medial surface, and an axial imaging is longer, more complex, and more posterior than the pars marginalis. Post-central sulcus usually bifurcates and form parentheses as a lazy Y, copying the pars marginalis. The anterior limb does not enter the PM bracket line, and the posterior limb curves behind the PM to enter the interhemispheric region. Okay, so essentially it's all here. The central gyrus is here, goes behind anterior to enter it. So I think it's just essentially here, goes down, comes like this, goes down. Central here, central. So it's not basically a description of all that. It's not such. And the next thing is the craniometric points. Here they're discussing the craniometric points on the skull. Very important things that need to be identified. generally looking at the skull bone. So we have some important junctions. Most everyone knows, of course, the what do you call it now? The pterion, which is supposed to be a union of four bones, which is the frontal bone, parietal, temporal, and the sphenoid bone. That's the pterion. And of course, it's important in neurosurgery for the pterional approach, which is, of course, the workhorse um, of skull-based neurosurgery. And also important in the sense that underlying it is the meningeal artery, and injury to this can result in an epidural hematoma. So, of course, so these are some of and it's one of the thinnest parts of the skull. Essentially, that's it. And then, so location is an estimated 2 finger breadths above the zygomatic arch and thumb's breadth behind the frontal process of the zygomatic. Good. Okay. Here, the thumb's breadth behind here, you find it. The zygomatic arch, 2 finger breadths, you find it. All right. So the next is the asterion. Of course, the asterion is a junction of the lambdoid, osteomastoid, and periotomastoid suture. So here is the asterion, the periotomastoid. This is the osteomastoid suture, and this is the lambdoid suture. The periotomastoid suture, osteomastoid suture, and this is the asterion. Yeah, and the asterion is important because of the location of the sigmoid and transverse sinuses around it. It's ideally within a few millimeters within the posterior inferior edge of the asterion is where the transverse and sigmoid sinus junction is located. And it's important in retromastoid approach because you want to work behind retrosigmoid and retromastoid, you want to work behind the asterion. There's behind the asterion, you have to prevent injury to the sigmoid sinus while you're doing the procedure. Of course, after you go a few and leading down the asterion, you have the mastoid groove. So posterior to it, 1 finger breadth posterior to it, and you make your borehole, and then you expand your mastoid creatinine. Of course, while you're doing your intramastoid creatinine, you want to actually see the sigmoid sinus so that you can protect it. Okay. Next is the vertex, the topmost point of the skull is here. The anterior to it is the bregma. Bregma is the junction of the coronal and sagittal sutures, and it's where the fused location where the anterior frontal is located. The posterior to the vertex, of course, you have the lambda, which is where the lambdoid and sagittal sutures fuse. And then Stephanion is the junction of the coronal suture and superior temporal bone, temporal line. So here, if you look for the superior temporal line and the coronal suture, where the joint is the Stephanion is above the pterion actually. And then the glabella is the most forward projecting point of the forehead at the level of the supraorbital ridge, midline. Yeah. Or the opistheon is the posterior margin of the foramen magnum in the midline. Yeah, here, opistheon. Of course, the inion is like the most prominent part of of the skull behind posteriorly. So you have the vertex. So anteriorly you have the glabella, mid and most superiorly you have the vertex, and the most posteriorly you have the inion. And going inferiorly, you have the posterior part of the foramen magnum, most prominent posterior part of it in the opistheon. And then I've talked about the sagittal suture, and then it's usually the distance, is usually about a thickness of 11 millimeters actually. So sorry, the SSS, superior sagittal sinuses, usually overlight, but they sometimes it is usually more tilted to the right of the sagittal suture in majority of specimens. But it does not go beyond 11 millimeters. So that's why most of the time when you want to do a craniotomy across the midline, they tell you to give an 11 millimeter a finger breadth away from the midline to put while you're drilling your holes, you're drilling your boreholes to prevent yourself from injuring the SSS. That's the basis. And then they said the most anterior mastoid point lies just in front of the sigmoid sinus. The other craniometric points in relation to the cerebral anatomy. First is the Taylor-Houghton line. So some of this, there are certain lines that can be drawn on your images that can help you give a rough estimate of the location of certain parts of the cerebrum. Some of the lines include so we have the Sylvian fissure and how to get it, the motor cortex, and how to estimate its location, a lot of other things. So some of those lines, example is this Taylor-Houghton line, which can be constructed on a CT, MRI, skull X-ray, or even an injury. So you have the Frankfurt plane, which is also called the baseline, and it extends from the inferior margin of the orbit through the upper margin of the EAM. So it's a straight line that goes from the inferior margin of the orbit here, like this. From here, it goes over here, like that. And usually, they use the Frankfurt plane as like a plane to orient the patient so that the slices of the CT, MRI correspond to that Frankfurt plane. And they call it the baseline, of course. While there's another baseline called the Reed's baseline, which extends from the inferior orbital margin to the center of the EAM, unlike the Frankfurt plane that passes the upper margin of the EAM. And the distance from the nascion to the inion, the distance from the nascion to the inion is measured across the top of the calvaria and is divided into quarters. It can be done simply with a piece of tape, which is then folded half twice. So first we've gotten our Frankfurt plane. And the next thing is to measure the nascion to the inion. So we go from here to here. And then we now split it into quarters. Quarter one, anteriorly, half, 3/4, and the 4th quarter. And then posterior ear line, which is supposed to be a line that is perpendicular to the baseline through the mastoid process. We pass through the mastoid process and we draw straight down. I think there are some images here that makes it very easy. Yeah, so this is the posterior ear line. Then the next is the condylar line, which passes through the mandibular condyle. So just take the mandibular condyle, which is anterior to the ear, external auditory nerve, palpate it, and then we draw a perpendicular line through it. Now, the Taylor-Houghton's line now is a line that can be used to approximate Sylvian fissure and the motor cortex. So, how do you measure it? How do you now measure both? So, the Sylvian fissure, of course, you go from so after you've done all this your craniometry, you've measured your what do they call it now? Posterior ear line. Posterior ear line is usually 2 cm from the half of that your nascion to inion line. right? So half of it, 2 cm behind that half, it corresponds to the posterior ear line. Then at that point where it joins the posterior ear line, so you now draw with your posterior ear line in place, you draw your posterior ear line. You now draw another line from 3/4 of your nasion to inion line. You draw another line across up to the orbit, the lateral wall of the orbit, a straight line. So the proximal 2/3 of that line, from the point where the posterior ear line joins that your line that comes from the 2/3 of the nasoanion line to the orbit. From that point where they bifurcate to the lateral wall of the orbit is where the sylvian fissure is estimated to be located. Then for you to get the central sulcus, you draw another line. Yes, of course, you have your condylar line. And then, so on your condylar line, you now measure from a line that connects the posterior ear line superiorly to the condylar line on your estimated line of the sylvian fissure. That forms your central sulcus. So that's the easiest way to identify the central sulcus and the sylvian fissure. Now, there are various methods, actually. There are up to 4 methods of identifying the motor cortex. So the method 1 is that they said the superior aspect of the motor cortex is almost straight up from the external auditory meatus near the midline. So you go close to the midline here. This is the EAM. You go close to the midline here. You find it. Yeah, so of course you can see if you go from, this is the EAM. You go up here. It's actually here. So that's method 1. Method 2, the central sulcus is approximate. So the one I just described before I talked about this is the second method. And method 3, using Taylor-Hunting's line, the central sulcus is approximate by connecting the point where posterior ear line intersects the circumference of the skull, really 1 cm behind the vertex and 3 to 4 cm behind the coronal suture. The point where the condylar line intersects the sylvian fissure. Okay, that was one I mentioned. So the method 2 is the one that they said the 0.2 cm posterior to the mid-patient of the arc extends from this, and 5 cm straight up from the EAM. Okay, so if you take from here 5 cm from the EAM, and then here you get your central sulcus, and then anterior to it, of course, is your motor strip. Then method 4, a line drawn 45 degrees to Reed's baseline, starting at the pterion, points in the direction of the motor strip. So Reed's baseline, as we said earlier, is from the inferior surface of the orbit, crossing the EAM. So they said if you draw a line 45 degrees to it, say 45 degrees to it, starting at the pterion. So this is the pterion here. And you go 45 degrees to Reed's baseline, starting at the pterion. It approximates, points in the direction of the motor strip. Okay. So if we pass through here, of course, approximates to the motor strip. Okay, so those are the 4 methods of identifying the motor strips. And the majority of time, all these descriptions has been overtaken by the use of neural navigation. Sometimes this may be asked. On this, so the other thing is identifying the sylvian fissure, which I've already talked about. In the skull, once it is exposed in surgery, the anterior portion of the sylvian fissure follows the squamosal suture and then deviates superiorly to terminate at the Chatter's point, which is located 6 cm above the AAM of the line perpendicular to the orbitomeatal line. It is also approximately 1.5 cm above the squamosal suture along the same perpendicular line. A 4 cm craniotomy centered at the Chatter's point provides access to the potential recipient vessels in the angular gyrus for an ECIC bypass surgery. Okay. So, of course, this is Chatter's point here. This is the Reed's. This one here is actually Reed's baseline. That's the orbitomeatal line. And then above it, 6 cm above, and 1.5 cm above the squamosal suture. So you can see 1.5 cm above squamosal suture. This is squamosal suture. Here is Chatter's point. And it approximates the angular gyrus. Overlying the angular gyrus. Okay. So the next is the ventricle. I'm sorry, yeah, though they talked about the angular gyrus that is located just above the pinna, important in dominant hemisphere as part of the Menikes area. Yeah. Relationship of ventricles to the skull. Okay. Said that the relationship of the non-hydrocephalic ventricle to the skull in natural view. Some dimensions of interest are shown in the table. So, in the non-hydrocephalic adults, the lateral ventricles lie 4 to 5 cm below the outer surface, skull surface, and the center of the body of the lateral ventricle sits in the mid-papillary line. The frontal horn is intersected by a line passing perpendicular to the calvaria along this line. Okay, the anterior horns extend 1 to 2 cm anterior to the coronal suture. And the average length of the third ventricle is 2.8 cm. Midpoint of Twinning's line should lie within the fourth ventricle. Okay, so important informations we've been given. So here, this is the coronal suture. The body of the lateral ventricle. This is the body, the antrum, the occipital horn, temporal horn, frontal horn. Now the frontal horn is about 1 to 2 cm for anterior to the coronal suture, right? Then it is so essentially what you do if you want to enter it. Yeah, so of course it's important. These dimensions are important in the Coca's point. You go a finger bent anterior to the coronal suture, because the coronal suture, of course, we all know straddles or is around the area of the motor strip, so you don't want to go there. So you want to go anterior to it to assess the frontal horn. When you're doing the Coca's access, that for EVD or BP shots. The body, of course, and everything is done in the mid-papillary line, which is approximately 2 to 3 cm from the midline. Okay. The width, as they said here, of the third ventricle is 2.8 cm, approximately 2.8 cm. And of course, we all know that the aqueduct of Sylvius measures approximately, it has its own measurement, approximately, they said it's a rule of 2, 2 by 2, 2 millimeters by 2 millimeters, I think, or 2 to 3 millimeters by 2 millimeters, something like that. That's the description for it. So, dimensions, D1 is the length of the frontal horn anterior to the foramen of Monroe, which is approximately 25 millimeters. So this is D1, 25 millimeters. D2 is the distance from the clivus to the floor of the fourth ventricle at the level of the fastigium. Okay, fastigium here. D2 is here. The clivus to the fourth ventricle, of course, at the level of the fastigium, which is the nucleus of the cerebellum. Yeah. So D3 is the length of the fourth ventricle at the level of the fastigium. Here, which is about, which is between 10 and 90 centimeters, average 14.6 cm. The distance from the fastigium to the opistheum. Oh, okay, sorry, they just said here that the fastigium, I'm mixing them up, is under fastigium, which is the apex of the fourth ventricle within the cerebellum. So this is the fastigium here, within the cerebellum. All right, and there's Twinning's line, which is this line. This is the anterior clinoid, posterior clinoid, up to the level of the inion, of course, where what do they say? The tocula. The tocula. Yeah. Sorry, please. All right, so essentially, close the door. So essentially, that's it for the ventricles. And it's expected that the midpoint of the Twinings line should lie within the fourth ventricle. So as it crosses from the anterior clinoids up to the tocular aerophyli, the midpoint of it should lie within the fourth ventricle. Okay. So those are the important structures. So here we have, this is 25 millimeters. This is between 30 to 40 millimeters, average of 32.6. That's D3. D2 should be within 10 to 19, average of 14.6. While, so that's, sorry, no, apology. D2 should be 33 to 40, average of 36.1. And D3 is the one that is 10 to 14. And D4 on the fastigium piston from here to here, which is between 30 to 40, 32.6 average. Okay. All right, so I don't know if anyone has any comments for now before we proceed. I think we're almost done. All the long stuff. Any contributions for now? Okay. So in absence of contributions, we will go to the next thing, which are landmarks. So landmarks, you have the cervical landmark, the landmarks of the cervical spine, which are very important. So we have between C1 and C2, the landmark is at the angle of the mandible, which corresponds to C1 to C2. C3 to 4 corresponds to 1 cm above the thyroid cartilage, which is approximate location of the hyoid bone. So hyoid bone corresponds to the vertebral C3/4 vertebra. Now C4 to 5 is at the level of the thyroid cartilage. And C5 to 6 is the cricothyroid membrane. And then C6 is at the level of the carotid tubercle. C6 to 7 is cricoid cartilage. Of course, majority of time, yeah, so C6, 7, the cricoid cartilage. 1 to 3, C6, 7, scectomy, ACDI. And of course, you can keep going upwards to assess the rest of them. This is an important information for spine and for anterior cervical discectomy and fusion anterior approaches to the spine. Makes your life easy. And of course, before you even localize, when you place your localizer, you're almost always correct if you use these landmarks to get it. Okay, so is the foramina in the skull and the contents, which are all, of course, important MCQ questions. A lot of other important things can come up from this. Those preparing from MRCS, you meet it, you'll be tired of seeing it. Those whatever exams, surgery exams, or preparing for the MRCS, it's always coming out, even in Part B. It's important to know. I don't think I will be going through everything. Really. All right, so we'll move to the next thing here, which is the internal acoustic canal. So there are 5 nerves within the internal acoustic canal. Commonly, everybody talks about 4, but there's 5 nerves actually, because the facial nerve is divided into 2. The motor part of the facial nerve and the nervus intermedius, which is the sensory part. of it. And it supplies mechanoceptors of the hair follicles and nerves of subpinal and deep mechanoceptors, nasal and buccal cavity, and chemoreceptors of the taste buds in the anterior two-thirds of the tongue. So it's actually an important nerve. It's important for taste sensation. So then, so we have, so the arrangement at the level of the pros acousticus. I think we've said it a lot in our discussions, but it's important since we're talking about it here. Is a 7-up Coke down arrangement. Of course, we know everybody knows 7-up and Coke, so it's easier to remember. That is the cranial nerve 7 is the facial nerve is superior and anterior, while the cochlear nerve is inferior anterior. The other two nerves, which are the superior branch of the vestibular nerve, that's the superior vestibular nerve, and the inferior branch of the vestibular nerve, the inferior vestibular nerve, are inferior at the level of the internal acoustic canal, or meatus, as the IAM, or the porus acousticus. Now, the acoustic portion, which is the cochlear, of course, serves to innervate the cochlea or the inner ear, and it subserves ear hearing. While the superior part of the vestibular nerve supplies the superior vestibular area. It terminates in the utricle and the ampullae of the superior and lateral semicircular canal, while the inferior part supplies the inferior vestibular area and terminates in the saccule. So it's important to know that. Right? So you have the superior, and the mnemonic is superior LSU, lateral and superior semicircular canal and utricle, while the inferior branch supplies the inferior vestibular area, terminates in the saccule. So utriculus, sacculus, the semicircular canal. Okay. LSU. Okay. All right, so essentially that's it for that. Yeah, we all know that there's the Bill's bar, which is the vertical crest that divides the superior part into anterior and posterior part. Of course, the inferior part does not have any separation. But separating the superior and inferior part is the transverse crest or crista falciformis. This transverse crest also has another name. Both of them have the Bill's bar vertical crest, transverse crest, crista falciformis, falciform crest. Okay. All right, I think that's it. So the last thing I will be talking about is the internal capsule. Of course, the internal capsule is a bundle of nerves that transmits the fibers from the motor strip to so it collects all the fibers and then they transmit downwards to form to supply the to fuse inferiorly. It has both ascending and it's just not just the motor strip, even the sensory cortex. So it has both ascending and descending fibers. Yeah, so you have various structures. So here you can see them here. Descending corticofugal fibers, ascending thalamocortical fibers. Right, so ascending fibers, which are this, and all the fibers have important areas, particularly the motor fibers, because injury to various parts of the internal capsule, that the anterior limb, posterior limb, and the genu, which is here, may have import. So look at import. The way you have the body having a form of homunculus on the cortex, you have the internal capsule also having its own homunculus, kind of, in the sense that you have the face, the shoulder, arm, everything as like a human arrangement in the anterior to the posterior part. Posterior limb, of course, the foot, anterior limb in general, face, shoulder, and all that in that arrangement. The important thing is to note that the corticobulbar tract is the most proximal. Here. So, and the genu is where the fibers are mostly condensed, as we are seeing here. So, injury to the genu may result in a dense or bleeding, or a stroke at that level may result in a dense hemiplegia. So, it's important to also know that. So, various fibers, including the corticobulbar, corticorubral, cortex to the red nucleus, corticospinal tract, which of course are general, also pass through this tract. For the motor components, of course. And then we have, for the sensory, we have the anterior thalamic radiation and the posterior thalamic radiation. Also, certain other ones, including the auditory radiation, which passes along it, but it doesn't really go into it. Optic radiation also crosses the area at the posterior limb, so it's important. For the sensory portion, as I said, various anterior thalamic radiation, posterior thalamic radiation, the superior thalamic radiation is also around that area. So I don't know if anyone has any contribution at this point. Because my last talk will be on the vascular supply to the internal capsule, the anterior choroidal artery. All of the retrolenticular parts includes the optic radiation, the ventral part of the posterior limb of the internal capsule is supplied by the anterior choroidal artery. The lateral stride branches or capsular branches of the MCA supplies majority of the anterior and posterior limbs of the internal capsule. The genu receives direct branches from the internal carotid. So, anterior choroidal artery supplies the posterior limb of the internal capsule and the retrolenticular parts. Okay, and then you have all this area. Majority of here is essentially supplied by the capsular branches or the lateral stride branches of the MCA. While here, while the genu here receives branches from the internal carotid, direct branches. Okay, so I don't know if we have any questions at this point. Okay, so if we don't have any question, then that brings us to the end of today's discussion. It's 9 o'clock on the dot, meaning we kept time. I don't know if I'm audible. Is anyone hearing me? Can anyone hear me?
Hello, yes, we can hear you.
Yes, we can hear you.
Yeah,
Yes,
we are hearing you.
Okay, I don't know if there are any contributions here. We were all following. Was it boring?
Yeah, no, we were following. Actually, we were understanding everything. No problem.
Okay.
The only thing, the last one, this radiation about the thalamic peduncles, that only I wanted to ask. The last one, this is basically, actually there are four. In this diagram also they showed this, anterior thalamic radiation, posterior, superior, and all these stuff they already shown. So basically they're telling that it's going to the frontal lobe, then the Ronaldic area superiorly, posterior occipital like this, and the transverse temporal gyrus of fistula.
Yeah.
This only.
So yeah.
This only.
Yeah, the anterior thalamic radiation goes to the frontal lobe. Yeah. From the medial and anterior thalamic nucleus to the frontal lobe. And the superior goes from the Ronaldic area, that's the area of the paracentral areas, to the ventral thalamic nuclei. Sensory fibers, of course. And that's the superior thalamic radiation, that's B. The posterior thalamic radiation goes, of course, this subserves the function of what they call it now, the hearing. I'm sorry, the posterior ceramic radiation from the hospital. Yeah, posterior, that's for vision. So it goes through, yeah. So this goes to the caudal, from the caudal thalamus to the occipital. So the sense, it goes from the occipital and posterior parietal area to the caudal thalamus. And then the inferior serves for hearing. So it goes from the medial geniculate, it goes from the transverse temporal gyrus of Escherichia, of course, the auditory area. And that's areas, Brodmann's area 41 and 42, as we discussed earlier, to the medial geniculate body. Yeah, that's where the auditory radiation is located, of course. So I don't know if there are any contributions. Thank you for reminding me.
No contribution, but I was thinking, how did you choose to end? Because the thing was still going. At what level do you end? Because on the timetable you said gross anatomy of the cranium and spine. So you didn't specify. You didn't specify which topic you are saying. The first presenter stops on. So we are not. Were we supposed to also cover these other things? So the pontine angle anatomy, those things.
Yes, we will tomorrow. We will on Monday.
On Monday.
Yes.
Okay.
Yes, in the next session, we will finish. We will continue from here, this chapter till the end.
Okay.
It's not so much. The rest is not so plenty. It's just about 4 pages.
Yeah, it's less. It's less.
Okay. So I think we're done. Thank you, everyone. We can, I'll stop the share now so that we can wait for the next session.
But we can use the same Zoom link. This is the same one or different?
It's the same one. So, but I'll
Same
stop
one.
the
Okay. So we will just be staying here in this one. Okay.